we'll probably save the questions for the end, and then we fix the technical problems with the previous speaker, so we can get back with Sabine and her presentation.
Okay, I hope that you can hear me, and I hope that it's not fading or something. Maybe someone gives me a verbal feedback if it doesn't work. So I was saying that we would normally, when we plan arrhythmia interventions, we would use 3D image integrations. We use a 3D mapping system. Of course, we have several choices. I'm going to show you the choices we have. We can choose what navigation strategy we do. And of course, we have also a choice of ablation energy by now. So I'm just going to remind you, this is a picture that I've seen shown very frequently. It's an MRI scan with the blood sequence, so we can see everywhere where blood is. We can do these beautiful 3D reconstructions that really help to plan the procedure, make sure that we know how to get into any chamber of the heart that we might have as a target chamber. And we can plan how, for example, in this TCPC, go into the tunnel, or if you go to the native atria, that is very easy to do. We typically merge, and this is an example of it, in the EP study over the virtual location of the ablation catheter. You can see that here is a gray volume, and that is merged over the aorta. The aorta doesn't move much. And that's essentially the trick of how we, in the even most complicated hearts, in combination, in this case, with magnetic navigation, but you could do it in a conventional procedure as well, move around essentially in the virtual 3D heart of any given patient. But in arrhythmia for congenital heart disease, as I mentioned before, it's very important to see the scar. Now, 3D LGE is an option here. We have contrast CT, late iodine enhancement, and of course there's intercardiac echo. Unfortunately, we don't have it really available at the Brompton, so I just say that for completeness. This is a nice demonstration of a scar, and the left ventricle is not particular. I think it's an ischemic patient, but anyway, you see the scar very well. That can be now implemented into the Cato system, and then again is a perfect roadmap. In ventricular tachycardia, is typically a channel through the scar. We can do that, again, this is from CT, enhanced CT scans, and then you can do the same thing. You can see these channels, and in fact, there is now commercially available software that allows you, when you send that or you process this data on a so-called ADAS 3D reconstruction, the system even suggests the channels where the VT could actually go through. We're trying at the moment to establish a project for the right ventricle. It's established for left ventricular ischemic substrates, and we're trying this in combination with Sonia Babun-Ryan and her team to implement that for right ventricular and subsequently for atrial arrhythmias as well. Now, I showed you that we have these sequential mapping systems. We used to use a single catheter moving around. By now, we have high resolution mapping. There's little baskets that have tiny electrodes, 64 in this case. This is the Rhythmia system, and that allows to just collect so many more points, and we have a higher resolution. You can see here an example of a right atrium of a patient with juxtapositioned appendages, and you can see beautifully on the video on the right how the reentry goes around this little scar, and we only have to connect here. You can see on the scar map, this is the size of the scar, and then you just have to connect this critical isthmus, block this channel, and that works. This is a larger cohort, actually the entire Brompton cohort published last year. That works, and you can see in the Kaplan-Meier curve here very easily and very successfully if the patient only has one single substrate. It gets much worse if the patient has a number of tachycardias. You can see it here on the right upper part. If 4 or 5 arrhythmias are present, typically in patients who have really enlarged Fontan circulations, very, very difficult to get on top of all the arrhythmias, and that's why, unfortunately, the freedom from arrhythmia is not as successful here. There are other mapping systems. There are simultaneous mapping systems that don't need the catheter to be moved around step by step by step, collecting the electrograms, but you can actually do this simultaneously. This is the Cardio Insight system that we have used a couple of years ago, where you put a big vest on with 252 electrodes on the patient's chest. The patient then gets a CT scan, and then from there we can superimpose all the electrical heartbeats beat by beat on the atrial or ventricular reconstructions and map those non-invasively. Very elegant, and then only once we have the arrhythmia documented, we can bring the patient to the cath lab. The next step for that, and we're actively using this now, is Vivo. Vivo connects an MRI or CT scan with 12-lead Holter information. This is very nice for the 3D reconstruction because we're no longer limited to CT scans, but you can also do MRIs. And the critical component here is a 3D camera that allows to have the patient's chest and the exact location of the EC stickers in place. It gives you also 3D reconstruction at the moment only from the ventricles. But again, we have used this for ventricular arrhythmia in a number of patients. We are just about to start a project in congenital heart disease. We've just done a couple of index cases. Now, if you think about the way of how we're using the moving the catheters in the heart, then of course magnetic navigation is one of the options to do that. So typically we move the catheters by hand, but we can move catheters, very soft catheters, by magnetic fields. I've put on the left side here the cardio drive. That is the forward-backward movement. This is a mechanical movement where the catheter is pushed or pulled into the patient's heart. And that allows to do all kinds of crazy moves. You see the catheter is very floppy. You can double loop it. You can typically go and perform procedures, for example, through a left SVC, through an azygos retrograde across the aorta, and allows to essentially do procedures in all of these patients' cohorts here on the left-hand side, or whenever access is an issue. The ablation catheter itself is exactly the same way as the conventional ablation catheter, so allows irrigated tip ablation. And you just have to go and collect all these points. We've done this now for, I think, as long as I'm 13 years at the Brompton, and this is a short overview of the cases, about 420 cases between 2012 and 2017, so 5-year period. You see that I still do most of the procedures manually, but the magnetic cases are about, well, maybe about half of the manual cases. But the impact, because of the image integration, all the other tricks that we are using, is actually quite immense on radiation exposure. Typically, a magnetic case has less than 2.5 minutes of X-ray, significantly lower than a manual case. We can merge with CMR scans or CT scans. It doesn't matter. Really, CMR is excellent in quality. And we can use it in conjunction with various mapping systems. My preference is CARTO, but all the other mapping systems are also possible to be used. The impact here, you can see comparison again, manual against magnetic, is quite significant in the supraventricular arrhythmias, including atrial fibrillation, but in the ventricular arrhythmias, we're still not as good, and that's work to focus on for the future. Now, I want to finish with this non-arrhythmia ablation because I find it very exciting. That's very recently published, I think a week or two ago, in JACC, where colleagues from Russia have used the magnetic navigation system to ablate within the pulmonary arteries to reduce pulmonary artery pressure in patients after fulminant pulmonary embolism, so CTEPH patients. And they did an invasive check of the pressures 12 months later and compared in a sham-controlled randomized trial the endpoints of pressure, of 6 minutes walk test, and a number of echo values. And you can see here that the denervated, so what they aim to do is to modulate autonomic nervous plexus here around the pulmonary veins. You can see here the ablation size in the left, in the right, left, and main coronary pulmonary artery. And that modulated the autonomic nervous system to achieve this reduction in pressure. So I find this very exciting. So let me conclude and say we can successfully treat essentially all arrhythmias, even in the most complex congenital patients. We have technical solutions with image integration. To understand the anatomy, we can see the scars better and better. We have high density, sequential or simultaneous mapping systems. And of course, we have magnetic navigations if it's difficult to get somewhere. And lastly, and I find very excitingly, we have neuromodulation, maybe a new way to consider ablations and magnetic navigation to treat congenital patients beyond cardiac arrhythmias. And I thank you for your attention.
Thank you so much, Sabine. Our next speaker, we'll introduce him again.